Good afternoon, and good morning to those joining us from the West Coast. My name is Jacinta Smith, and I am the Program Manager for PCPCC Support and Alignment Network. On behalf of our SAN, I want to thank you for taking the time out to join us for our webinar on activating patient engagement in care delivery. There are a few housekeeping items I would like to go over before we begin. We have a lot of rich content to share today, so you are encouraged to participate during the webinar by typing your questions and comments into the question panel. We will answer questions after the presentation, but please do not wait until then to engage with us. Today's webinar is being recorded and will be available on our website 24 hours after the event. The link to access the recording and other resources will be posted in the chat box shortly. So without further ado, I would like to introduce our speakers for the afternoon. Our first speaker will be Mary Manetti, who is a Senior Policy and Program Specialist at the Institute for Patient and Family-Centered Care, which is also a partner organization of the PCPCC SAN. We will then have two special guests, Amberly Takasi and Ziva Mann from Cambridge Health Alliance, who will share how patient engagement has influenced care delivery in their health system. Thank you again for joining us, and I'll turn the presentation over to Mary at this time. Mary?
Great. Thanks so much, Jacinta. We're so glad that you could join us. This is an important topic for those of you that are in the Transforming Clinical Practice Initiative, because what we want to do is discuss and describe the performance metrics on patient and family engagement. We are fortunate to have Cambridge Health Alliance with us to share their story of how they've really been effective in engaging patients and families. And then I want to share with you some resources that are available to support your patient and person and family engagement practices in your direct care strategy. So the Affordable Care Act is what provided the funding for the Transforming Clinical Practice Initiative, and it's all around promoting and advancing and preparing practices for broad payment reform and practice reform. And so the whole idea is to improve outcomes, improve person and family engagement, and to promote quality and reduce costs. One of the things that's really important to remember in terms of the context and the healthcare environment in which we live these days is that CMS has adopted person and family engagement as a strategic framework, and so they're going to be looking both in their value-based payment and in other places to ensure that practices and clinics are preparing to transform in partnership with those that they serve and their families, because without that engagement, they believe, and evidence shows, that we are not going to be able to improve the healthcare experience and the outcomes that we so desperately need. And so it has all to do with co-creating goals and being sure that we really understand what the preferences and goals and values of those that we serve are, so that we can really promote best practices in patient and family engagement. And you'll often hear in articles that you read in other places, people will say patient engagement, patient and family engagement, or person and family engagement. All of those ways to discuss it are interchangeable. What's really important is to recognize that it's all about creating an active partnership between those who provide care and those who receive care and their families who support them in their health. There are lots of articles out there regarding the evidence, the best practice evidence related to PFE, person and family engagement, but I want to bring your attention to a recent white paper that was produced by the National Academy of Medicine related to harnessing the evidence and experience to change culture to a patient and family-centered care system. And what they found was that, and they gathered lots of evidence together, is that there are a number of outcomes that we all care about when we are effective at engaging those we serve and their families. One of the things that is especially important, especially in primary care now, is that there is really a burden for the transformation, and anything that returns joy to work is important to pay attention to, because we are losing providers, unfortunately, too frequently from burnout. And what we find is with good systems that encourage and promote and support person and family engagement, that it improves the staff experience, it reduces burnout, and it reduces job stress. And that's really important because the caregivers are in a difficult place to give care if they are feeling burned out. But it also improves transitions of care, which affect costs. It increases the success of people in self-managing, and it reduces the costs of hospitalization and using emergency rooms when it's not an appropriate thing to do. So one of the things that we really want to speak to is that person and family engagement is a primary driver, and it's a driver that can really help in the transformation to prepare practices, because as part of the new quality payment program in the MIPS scores, you can receive additional value-added payment based on patient satisfaction and medication management, advancing care information through patient portals and e-prescribing and a number of things, as well as improvement activities for engaging patients and inviting them to participate as improvement partners with you as you're transforming your practice. So we want all of you to be ready for the quality payment program, and that is part of the technical assistance that's available through the TCPi project. So I want to talk about the metrics for a moment because they are required as part of the TCPi program. And I want you to be assured that the metric selection was not a random, quick fix kind of thing to create additional burden, but it was to encourage and enhance the efforts that practices are making. And in terms of selecting the metrics, we've been working on this for over a year. We created a patient and family engagement advisory council primarily made up of people across the country who were experts in quality, who were patient and family advocates, and who looked at a very high level at what are the drivers, what are the things that really impact person and family engagement, and how can we measure those things to see if practices are making progress, and measure in a way that doesn't create undue burden. And so that group created a framework for measurement, and they prioritized 6 areas for metrics across all practices. And the diverse membership really helped all voices be at the table so that we could really create a win-win situation. So clinicians were there as well as patients and family members. So, oops, that moved a little fast. For those of you that are in the TCPi program, we are in the process right now in April and May of establishing the baseline on 6 metrics. And they are going to be collected not through a survey, but through conversations and interactions that you're having with your practice transformation network partners. And so we will be gathering that information through the PTNs about what people are doing in terms of the 6 metrics. And then in an ongoing way, again, to not reduce burden, those questions, those 6 metric areas, will be integrated beginning in June of this year into the PAT, which is the practice assessment tool that practices are filling out on a 6-month basis once they begin the process of being involved in TCPi. So there are 3 areas that the metrics cover in terms of person and family engagement. One is point of care, policies and procedures, what are the systems that we're creating that really embed person and family engagement into the fabric of the work that you're doing, and also in governance and operations improvement. So there are 6 metrics, and you can see them there. Today's webinar is one of 2 webinars that we're doing, and I'm and Cambridge Health Alliance are focusing on 3 of the metrics: shared decision-making, patient activation, and health literacy surveying. So in terms of engagement at the point of care and creating the systems to support that interaction between patients and clinical team members, we really need to support self-management and shared decision-making, and it relates to goal setting and what kinds of aids we have, how we pay attention to whether or not our patients are understanding information that's being shared so that they know what action that they are capable and willing to take in order to do that. And so it's a continuous learning cycle between patients and the clinical teams. The question that's going to be asked and what we're looking for in each of the practices related to shared decision-making is, does the practice support shared decision-making by preparing and training the clinical teams to integrate patient-identified goals, what are their preferences, what outcomes matter to them, and what are their concerns into the development, the co-design of treatment plans. And so we want to be able to respectfully integrate a patient's culture, their language, what's important to them on a spiritual dimension, and address any concerns often related to social determinants of health. And the intent of this metric really is to elevate and encourage and support patients and families as being equal members of the care team. So that's the purpose of the shared decision making. Now what we know is that there are so many studies that say that more engaged patients achieve higher levels of quality and safety, fewer errors, less safety concerns, an improvement in self-management. And that's really what the TCPi project is all about. And it's also what gets providers into medicine. They want to make a positive difference in people's lives. The second measure that we're going to talk about today is patient activation. Does the practice utilize a tool to assess and measure activation? And the intent of this metric is to really understand the patient and what their individual needs are in the framework of activation, which really is a combination of what's their overall knowledge about their health and their conditions, what are their skills in managing those, and what kind of confidence do they have that they can self-manage. And what we really want to be able to do is support them, because what we know is that studies show that if somebody has a low activation, that is that they don't have many skills in managing, that they don't have knowledge about their condition in ways that they can understand, if they don't have confidence because they haven't had a lot of experience in setting goals and meeting those goals, those activation levels can be very predictive of what kinds of outcomes they're going to be getting. And so the important thing is to individualize care based on a person's needs and their skills, so that we can really encourage their activation by meeting them where they're at and moving forward to continue to build those skills and competences. The third metric that is going to be measured in the TCPi project is health literacy. What we know is, and the intent of this metric is to ensure that practices in terms of their systems are being systematic in addressing health literacy issues, because we can't assume that somebody who even is college educated is health literate, that those are not necessarily the equivalent. And health literacy is about how well we understand our conditions, but how well we can also navigate the healthcare system. So how does the practice in some way, and this is the question, is the health literacy patient survey being used by the practice some way to assess that our efforts at creating a more health literate organization that supports the growth of a person's health literacy is being effective? And this has to do with, again, communication and the importance of communication and connecting with people where they're at, and speaking and sharing information and providing tools that help them make sense of their healthcare situation, their conditions, and those kinds of things. And unfortunately, 40 to 80% of people that attend a medical office visit forget their information, or they misunderstood what they heard. And so understanding health literacy and addressing those issues in systematic ways is really important, because what we really want to do is use tools like decision aids to improve a person's understanding of their condition and how they might be able to create a better and healthier life for themselves. So I want to turn it over to Cambridge Health Alliance to share their story of their partnership, because they have done an exemplary job with a very diverse population to really embed the issues of activation and literacy into the way that they approach shared decision making with their population. So I'd like to turn it over. Eva?
Thanks, Mary. And thank you for inviting us to join you. It's a pleasure to be here. So we're going to introduce ourselves, give you a sense of who we are and why we started using care plans, how we got to where we are now, a little kind of peek at some of the training that we do to help staff get into the right place to do care plans, what it looks like, give you some examples, and talk a little bit about impact. All right, so CHA, we're a safety net. We're outside of Boston. We're in a number of cities there, as you can see, 12 primary care clinics. We have a public health mandate, so we've been working in community health for quite some time. And as you can see, we've got a fairly diverse group of patients. 82% public payer, almost all of them are Medicaid, over 50% patients in speaking a language other than English. We spend a lot of time and funds on translators. And if we want to get change done, we have to persuade 18 different labor unions. Now, we are going to focus a little bit on some of the work that is done across the primary care system, but specifically looking at Union Square. Really?
Hi guys, I'm Amberly, and we're looking at Union Square Family Health specifically because, as you can see on the screen, we've been acknowledged for some of the work that we're doing, but we also have a diverse patient population that has enabled us to get creative to find ways to get the funding that we do have. And I work there as a nurse, so a lot of these examples are coming directly from my clinical experience. So when thinking about patient activation, health literacy, and shared decision making, CHA and Union Square, we decided to focus in one specific area and make one change. So we decided to create care plans. We know that patients spend a very small amount of their day and their lives actually at patient appointments. So how do you impact this? How do we make real change and actually impact patients? So we know that patient activation, we know that these things work if we can do it. So how do we do it? For full disclosure, we did have some funding related to this, which helped get us started. But since then, we've really taken it on and feel that it's been worthwhile. So we've included it even though the funding has ended. So we first started pitching it as a documented conversation between providers and patients. Providers were not very excited about this idea. There's a lot of things that we're all responsible for doing and not a lot of time to do it. These are some of the responses that we got from providers when thinking about starting a care plan. So we had to think about how to frame it, how to create a real care plan that would create the change we were looking for, and we started again.
The last thing we want you guys to think is that we've said to ourselves, oh, we need a pragmatic and efficient way that potentially can get paid for to engage people in their health and give us a sense of what matters to them and make sure that our care is effective because we're already tight on funds. In fact, what really had to happen for this to work is we learned our way forward. Our first care plan actually was done, it was in fact a needs assessment. It was done by somebody we got borrowed from DPH, who specialized in need assessments that she did in the homes of children, medically complex children. And we've come a long way from there, baby. The first patients who went through that needs assessment told us exactly how, I believe the words were, depressing and soul-sucking it was, because it focused only on what was wrong. So we needed to change gears, and we actually spent about a year really revamping our care plans. What we learned, first of all, you have to engage staff. They need to tell you what they have the capacity for, what they have the skills for, what they're prepared to do. You have to engage patients. Patient did a care plan. We said, hey, how'd that go for you? And they would give us feedback. And we also learned that we had to engage people who were already using things like patient activation and had the skills to help guide us in these things, like our complex care managers. So we took the revamped care plan. You can see on the left to some patient partners. These are patients who work with our improvement teams. And they said, there is way too much text here. There are questions here that people are not necessarily comfortable answering. You can actually see some ink next to some of those. You need to pare this way, way down and make it simpler. And so we did. We took it down to the one that you see on the right. And then we tried to pitch it again. And this time, we took a different approach. First, we gave people a concept. We kind of set the mindset that they needed. Then we walked them through the workflow. Then we showed people that they have actually already got the skills they need to do this. And we found peer champions who would lead the way for us in making this change. So when we talk to staff now, what we say to them is essentially what we're using is a language of readiness and activation. But we say, basically, imagine that health is a car. And people might sit in the front seat and they might drive the car, they might ride in the back seat, or they might even try to not think about being in the car at all. It all depends on what they're ready for, what they've got the skills for, their understanding of our healthcare system, how to navigate it, or what other pieces of context are in their life. So you can see right there, we're folding any number of different elements from these metrics into this concept. And then we tell staff, ask people, what are you ready for? Ask yourselves, what can we do to support you at this point and stage in time? What skills, knowledge do you need in order to kind of move forward? What relationships will help? So basically map the context of where this person is emotionally, mentally, in terms of their resources, their capacity. Ask yourself where they're going. Where's that car going? Or, are you even in the same car? Very often we're not, right? If I'm worried about your blood sugar and you're really worried about whether or not you're about to lose your housing, we're not in the same car. And then always ask why, right? Why are they sitting where they are? What's going on? What's shaping their current situation, mindset, capacity, and respect it. And this last piece was really important. What we were asking staff to do is not to treat patient activation and engagement like it's a light switch that you can just flick on with one easy move, right? But instead, think of care plans as something that was going to grow and evolve over time. That this was your chance to start the conversation.
So with that in mind, we started figuring out what our goals were for the care plan. You can see the list here that we sort of came up with, but we really felt like this led to us being able to look at these three metrics that we're talking about today: patient activation, health literacy, shared decision making. Understanding where patients are and managing their health, understanding their priorities, these all are engaging patients, activating patients, and leading to health literacy. Creating the shared plans, developing action plans with the patients. This is engaging, modeling patients. It is so important to build relationships. These last 4 points, I think, really speak to that. We're building trust. We're building relationships with patients. These are patients that we're going to be seeing in a month, in 6 months, in a year. Their goals, their care plans are going to evolve. We expect discussions to continue and change as their needs change and as their health changes. So it's really important that we come alongside them and that we keep talking to them and changing with them. I think this is really important as we get to team-based care and a lot of this transformation that we're doing in primary care. So many team members, so many different people are involved with patients now that the care plan really allows all of the team to start at the same point so that patients aren't repeating their stories and repeating the same goals, but that they can actually be moving forward and feeling that we're all with them at the same point, moving forward together. And that, I think, is really important and really came through that the care plan needed to be accessible by everyone in the care team, not just providers, not just specialists, but nurses. MAs, even front desk staff can view the care plans and edit them, because a lot of times front desk staff are the ones that hear that their car broke down and they didn't know how to get to the doctor's office that day, and they can update and share those barriers or those new things that have come up that are really going to impact what their care actually looks like. We also really liked care plans because they build on things that you are already doing. We go into healthcare because we want to take care of patients, and this let us get back to the basics. You're just talking with your patients. You're getting to know them. You're meeting them where they're at. These are things that, you know, in nursing school we talked about motivational interviewing. These aren't new concepts that you have to be teaching patients or your staff. They're already in your toolbox. You are already doing these things. It's just putting it into a context that the patients can understand and feel that they're a part of, and that staff are able to identify as patient activation, as shared decision making. It's not doing new work, it's doing the work you're already doing in an intentional manner. The next slide shows, this is actually the care plan that we now use. This is what we have in our electronic medical records. You'll note that the stars, actually, we can use keyboard shortcuts to edit those, but and there is some drop down that's noted here, but this is what our care plan looks like. It's 7 questions, even though it says 6 in 1. It is 7 questions, and it takes very little time to actually go through the questions, but it's a whole discussion that can really help to shape your appointment and your plan with the patient. We know that it's been successful when patient language is used in the patient goals. We know that it's been successful when barriers are noted, and they're often physical, psychosocial, and social determinants, and that we acknowledge those. And then the confidence levels. This is patient activation. How sure are you that you can follow through with this plan that we just made? And all of this is evidence-based, which is so exciting.
So as you tell, things are going pretty well, and inevitably the thing that happens at that point is that you run into a monkey wrench. One of the things that we learned was that people don't know how to make plans, which is to say they don't know actually how to reach their goals in manageable, realistic ways, what concrete steps that you need to take in order to get there. So one of the things that the patients who are working with us, one piece of feedback they gave us is, it's really great, but you know how often I go to my doctor's appointment and somebody says, all right, I'd like you to lose about 15 pounds. And then the thing you say is, okay, and then you go home and you have no idea how you're actually going to get there. So SMART plans are part of the care plan process. And we were actually very lucky that Tom Bodenheimer shared with us some of the strategies that he's been using for self-management. And we turned it into this nice looking handout. Now, the My Goals, My Plan is actually a variant on a general assessment that we give out to people. We have a pediatric and adult version, which basically says, what are your goals right now? You know, what could keep you from reaching your goals? Who can help you? And there are other versions of this, and on diabetes versions, they will ask you, like, what are you interested in learning about or discussing today? There's other cues.
Just to note, this is a handout that's included with the webinar today.
Yes. So what we added is this, to kind of help people narrow down their goals and think about what it is that they actually want to tackle. Because we do have care plans where the patient lists about 3 or 4 goals. And let's be clear, teaching people to set goals is part of modeling what's possible for people, saying, here's what you could do. It's an invitation to engage as deeply as the person is ready to in their health with their care team. And people don't know what's possible. They have to be given ideas. They have to be given specific invitations. They have to be allowed the opportunity to learn their way forward. So part of it is, how do you set goals? Part of it is, what's your plan? Specifically, what are you going to do? How much of it are you going to do? When? How often? Where? The care plan is set up to help people think through each of these steps concretely, so that when we end up doing a little motivational interviewing, they don't have to rethink it. They've written it out with us. And the power of a shared piece of paper between patient and provider is tremendous.
So as a nurse, I see patients every day that have different goals or concerns. It's very common to hear that that patients don't understand why their blood sugars, why their A1Cs came back so high. They're still taking all their medications just like they're supposed to. They promise they've been doing just what you've wanted them to. And my goal for them is that their A1C is less than 7. But when I talk to them, their goal is to play with their grandchildren and be able to get down on the ground and play. And so we're coming at it from different angles. So we keep talking, and I find out that just getting active is hard for them. So the goal is actually that they walk around the block every day. That they, maybe that they reduce their rice portion, and that they continue to take their medications on a regular basis. Maybe their goal is that they need housing. They need that stable place to be, while my goal has been that they get off their opioids. That hasn't been their first thought. So talking it through, making sure we all are starting in the same car, and then moving through the questions with them. Sometimes identifying those initial goals really helps you figure out where to even begin with. Sure, I will tell a story. I saw a patient recently as we were planning for this webinar, actually. He came in and his A1C was 12.5. And he was actually seeing me for a blood pressure check. His blood pressure was okay. It was about 145 over 95. Not quite where I wanted it to be, but not so far out of range. We're sitting and talking about hydration, and the Boston winter's been pretty mild this year. We didn't get as much snow as we've had the past couple winters, but we got a pretty big snowstorm recently, and he was saying that he just couldn't get out, that his back hurt from shoveling, and I learned that he works 2 jobs to help support not only his wife and him, but also their daughter and the daughter's children, and that there was a lot of stress associated with how to get enough money to care for all of them and do the things that he was hoping to do. And as the man of the house, he really felt this responsibility and a lot of weight related to that. For him, eating healthy wasn't even a thought yet. He was thinking about much more basic needs and much more concerning, pressing issues. So as we're talking through, just understanding where he started from and all the weight he was bringing into the clinic with him was so important. And we actually figured out that the recommendations that he had been hearing from the pharmacist he'd been seeing didn't apply at all to him, because he worked mostly night shifts. And so he needed to actually change his diet pattern so that his diabetes could be controlled in a way that made sense, because he was eating mostly overnight, not during the day. So when he was checking his blood sugars it wasn't making sense with how he was actually eating. So we weren't getting good data from him, and nothing was correlating. And so just understanding that he was mostly working overnight shifts changed everything. And it was able to be reflected in the care plan. And when he met with the pharmacist last week, I actually heard doing much better, and he was feeling a lot better. We haven't been able to recheck his A1C yet, but we'll see how things go. But it was just an exciting kind of breakthrough that we had as a team, and he was feeling a lot more supported, and it was something that we were able to share amongst ourselves and with him. So as you've kind of heard from my story, we really like it. Care plans have been really great for us as staff. We feel like patients are actually engaged. The goals aren't to lose 20 pounds, but it's to walk a little bit more, to get a little, specific exercise goals, but just a little bit more, not to hit the gym 7 days a week for 3 hours every day, but real attainable goals that were, that we're actually being able to impact the patients that we're seeing. And it's not just these long shot, shoot the moon kind of goals. And so, the care plans have really allowed us to focus and feel like we actually are working on patient activation, health literacy, that the decisions that we're making are shared, and that we're getting back to the things that matter to us in healthcare, the reasons why we got into healthcare. We're able to impact patients, and we're able to use that appointment time not only to address their medical needs, because we really are addressing their medical needs, but that in doing so, we're also able to kind of slow down and hear patients and get back to those basics.
So from the patient perspective, we think it works too. We have some quotes that we pulled out of some individual care plans. I feel really sorry, I have to admit, we were in the middle of compiling data on outcomes. And so we were able to do a review of a number of care plans, but we aren't able to give you what we would consider strong enough data. Get back to me in a month, we'll have something. So these people are trying to help me and I should listen to them. That's a person who has diabetes. Their A1C went from 9.4 to 8.3 in 6 months. They lost 16 pounds and cut smoking by 1/3. The person who loves her PCP, or his PCP, has asthma, depression, diabetes. The goal was to lose weight, lost 15 pounds. I'm going to say right now, I actually just picked the top 3 care plans in the pile, and I wrote down their outcomes. I didn't pick the ones that make us look good and shiny. I felt like I wasn't just another patient. That was somebody whose goal was losing weight and quitting smoking. Now, the only comment I have there is that there's a note that says achieved goal is losing weight, and that the patient feels better. She feels that she's caring for herself better by drinking more water and tea, less caffeine, doing exercise, and taking her meds. And this particular patient also cited support from the team at the clinic as being key to getting this done. She said it was nice that someone was able to ask about my goals and that my PCP, well, she said doc actually, cared enough to ask. Now, if you look at it, you can see we're getting the work done. And that last quote, I think for me at least, illustrates that it's not just that the work's getting done, it's that the work is now truly becoming collaborative. I did an interview with one of our providers who said that she had been initially quite skeptical about care plans, which is fair. And she did her first one, and it was on a patient who needed to get more exercise, and the patient walked back in afterwards and said, for the next appointment, and he says to her, "All right, doc, here's what we're going to work on next." And they went from there. So I think if you guys take anything away from this, it's first of all, It's okay to fail your way forward. Your patients will help you. Your staff will help you. There are people who've already invented this wheel. Stopping and listening to patients really benefits everyone. We're not just looking at the patient side of the equation, we're also looking at the staff side. And it's actually remarkably easy to hit all three of these metrics. For us, the care plan is basically a semi-structured guideline that we're asking people to document, and it's very simple to document, that allows a really, really crucial conversation to happen, something that's at the heart of care. And with that, I'm going to hand this back to Mary.
Great. Thank you, Amberly and Ziva. What a great practical example of how to be utilizing knowledge and skills around activation and health literacy to do some shared decision making with patients. What I'm going to do in this last few minutes, and we'll still have time for questions, is to very quickly go over and share with you some resources that if you are looking for resources so that you can answer yes to the question, we are training for shared decision making, and we are using patient activation principles and health literacy principles in the way that we are engaging with our patients and families, that you've got some resources that you can take a look at. Some of them are in the downloads, but all of these presentations are, or these resources have in your handout the link to get more information. So AHRQ has created a variety of resources related to patient and family engagement, and they have a shared decision-making resource called the Shared Approach. And it's a curriculum that's already been developed with some videos and things that make it very easy for a practice, small or large, to do a lunch and learn and help begin the process of thinking about how are we doing shared decision making and are there some opportunities for us to improve it. And in the PFE metrics, what is really important is for practices to be thinking about how to create systems that are going to be useful to them. And so it is important to find tools that work and are useful. The Mayo Clinic has a series of paper, downloadable shared decision-making tools that make it easy in real practice, and they've researched them and they're available for free online, and they've got all kinds of tools. These are some examples of cards that you can have when you're having a conversation with someone with diabetes to help them identify, you know, of these things, what are you interested in working on? And so that's a resource to you. HealthWise has a variety of decision-making aids because they've combined with the Informed Medical Decisions Foundation. And so they've got some resources as well. There are more resources out there, but these are some of the key best practice resources. In terms of patient activation, sometimes it's important and useful to see how people are using patient activation in their practice and how they're integrating it. And so there was an example of a small team that used the patient activation measure to customize how they provided care to patients. And on your left side are the questions that are the patient activation questions. And you can certainly work with Insignia Health or with your QIO to do the full meal deal related to patient activation and get whether they're level 1, level 2, level 3, or 4. But also just using these questions in conversation with patients. Do you understand what your medications for? I understand what my medications are for. It's a statement, and the patient, you know, strongly disagrees with that or strongly agrees with that, and is anywhere along the continuum. It gives you an idea of what you might be able to work on with the patient to help them. Motivational interviewing is a way to increase patient activation, and the ACP has a practice advisor curriculum. It takes less than 30 minutes for providers and staff to fill out. There's a biopsy for your program on what you're already doing well and building on that, and they have one on motivational interviewing, which can help you with your patient activation. And then, the confidence scale, this is not going well, is just a really easy one and was spoken to with the Cambridge Health, the 0 to 10 confidence. The CAPS Health Literacy Survey is available. The questions are available for free. I've shown you some of the questions that are there. to get a sense of whether patients are feeling like we are, as providers and clinical team members, really connecting with them in ways that are helpful. And they really, in terms of health literacy, fall into 5 areas: communication, understanding around disease self-management, medication, test results, and forms communication. All those things are really important in order for people to be able to manage their health. There are additional resources just generally. At the Institute for Patient and Family-Centered Care, we have a number of resources that can assist you in engaging patients and families. And if you are interested in joining our free PFAC network, which is really people that are interested in promoting and ensuring that patient and family engagement is embedded into all the work that you do, and you're interested in learning from other people that may be farther along in your journey, you can join the PFAC network and pose questions and get resources that are practical and easy to use that other organizations have used. The PCPCC SAN has a variety of resources on their website. They have a resource library. They have things for patients and families as well as for clinicians. And the whole point is to promote person and family engagement and give people practical resources with things like this webinar and recordings from previous webinars about ways to change the culture in your organization to improve outcomes and to invite patients and families to be full and active partners of their care. So resources are out there. I think that the point being that what we really, really want you to be thinking about is how can we take the ideas related to these 3 measures at the point of care and also in terms of the systems we create to support staff and clinicians in building the kinds of relationships that engage people where they're at and build their skills and confidence to be able to improve their health. So we have left time for questions, and I think that there may be a few. I know we have a couple hundred folks, and there's a number of people that are concerned about how they're going to be able to respond to these TCPi metrics in an affirmative way. So I'm going to turn it over to you, Jacinta, so that we can give people an opportunity to ask questions, both of Cambridge Health Alliance related to any tips and other tools that they might suggest, as well as any questions about the metrics and what might qualify as a yes, we're utilizing patient activation or shared decision-making in our practice.
Sure. Thank you, Mary. So we have about 9 minutes or so to sum up some of the questions that have been logged into the chat box throughout the webinar. And so Ziva and Amberly, we have a few questions about the care plans. So first we'll start off with one. Someone was asking that we've heard a lot of success stories about patient engagement and how, how successful the care plan initiative has been, but others are curious about some of the challenges with patient engagement in regards to kind of keeping the patients engaged. So after they come, they're excited about their care plan, and everyone makes their goals, and then the patient leaves. How do you guys suggest that, the providers or the healthcare staff kind of keep those patients engaged and involved in their healthcare? What can they provide to kind of really have them motivated to continue with their motivation with keeping up with the care plan and reaching the goals that they've listed on their chart?
Well, so I think, first of all, don't underestimate the power of actually really stopping to listen to somebody and asking them what matters to them. When we ask our patients, basically, they say because they have a relationship with their provider or a relationship with their care team. I would say there are a couple of things you can do. First of all, when you think about the patients, some people are going to relate better to a nurse or an MA than they will to a provider. It's a lot easier to have a very blunt conversation about whether or not you're really going to be able to go for a walk 3 to 5 times a week in the neighborhood that you live in. The other thing is, over the course of that conversation, based on who you think they'll relate best to, have that person do the care plan with them. If you then think also that this is somebody whose life is sufficiently complex that they're not necessarily going to reliably come back, think about setting up a telephone encounter and checking in with them by phone. You really do have to be practical about it. Did you want to add anything, Amberly?
I guess I would also just say to hang in there. This also takes patients some time to get used to the fact that you're stopping and listening, and that it's no longer this one-way street of information, and that people actually want to talk to them. So be patient, keep up with it. You know, sometimes as the provider of care, you may be helping to direct them, or like, you know, you be a little suggestive at first. And then as patients get more confident and more comfortable, they really start driving the car. So I guess at first you might be driving the car and you're inviting them to come into the front seat with you, and then you're inviting them to start driving the car. So hang in there and keep at it.
Thank you. So we have another question about the shared decision-making metrics. It was asked, can shared decision-making be used with any health condition or behavior? So for example, hypertension, tobacco cessation, etc. So Mary, I think that's more towards the metric side.
Yes, and the answer is yes. Shared decision-making is really a process where you're engaging the patient to find out what's important to them, what outcomes they want, and it can be around a particular condition. So how I might do shared decision-making with my doc right now, because I have plantar fasciitis, that's around a particular condition, and what kinds of treatments and approaches that together we're going to take. I'm doing shared decision-making now, but if I develop a different condition later, that process of how he and I together come up with solutions and ideas on addressing my health issues is something that can be applied to any condition that somebody has. Even somebody who is not developed a chronic condition but has is young and is interested in maintaining their health, you can do shared decision-making around that. You know, what are some of your options? What's your lifestyle like? What might you be willing to contribute? And here's what I can share as a medical professional about what helps people maintain a healthy, their health that they have right now. So yes, the answer is yes. If you are doing shared decision-making on any condition, that process, you start where you're at. And so maybe you start with diabetes, or maybe you have more patients with high blood pressure, so you get that shared decision-making process down. And then you expand it to other kinds of conditions, and eventually with all patients. But start small, and that's considered patient and family engagement, in that you can say yes to that metric because you've trained your staff and your clinicians on how to have those conversations, how to understand the importance of listening and identifying what people are able and willing to do, and then you just apply it to other conditions over time.
Great. So Ziva and Amber, another question about the care plan. It was mentioned that the plans are typically printed out and given to the patient in paper form, but then also you mentioned having access, the healthcare provider and the staff having access to these plans as time goes on. Someone to know if, you know, if the care plans are printed, how can the other healthcare staff kind of update them? Are they having to bring the plans back for updates, or how are updates made if the patient has them in paper form?
Great question. So our system actually allows us, so we use Epic, and in the problem list there is a function on the top where you can write anything. I'm not sure exactly all the IT portion of it, but the place where we document the care plan is included in the chart, and it prints in the patient after visit summary. So you can do this regardless of your type of electronic medical record, but documenting it in the progress note or somewhere that the patient can receive it at the end of the visit, but that it also stays in the patient electronic medical record allows for that to occur.
Great. So it sounds like it can be an electronic document if it's in the EHR, but the patient also has access to it if it's printed off for them after the patient visit.
Right.
Does,
Great.
Amberly, can I ask a quick question? If you've got it in the EHR, can they see it on the patient portal if it's a patient who wants to use a portal?
That is a good question. It would show up in the after visit summary, which I believe is accessible from the patient portal, but it would depend on your patient portal and how that what goes into that. So that would take some questions to your IT department. But I'm sure you could like set it up so that it is accessible.
Thank you.
Thank you.
I think even more important than having it accessible through the patient portal is really giving people a piece of paper to go home with, and preferably a piece of paper that you've both written on, because we find a lot of after-visit summaries in the recycling, it's the trash. But the papers providers or nurses or MAs and patients work on together, those people tend to keep.
And this question kind of feeds off of your statement. So are there health coaches as well as care managers that help the patients in developing their care plans, or is there someone specifically on the care team that's assigned to work with the patient on the care plan? And when is it done? Is it while they're waiting in the waiting room? Is it during the office visit, or is it part of like a follow-up email?
We mentioned complex care managers because they had more experience working with patients who needed to make successful, simple, clear plans. They're actually not, we're talking about care plans that are being used with the broader population. And we don't have health coaches actually involved. It's really any member of the care team.
To get like super specific and a little bit annoying, we do have nurses do go through and make sure that care plans have been updated. So it is the responsibility of the nurse to make sure that they're completed, but it's not necessarily that the nurse has to complete it. It's that they're the one sort of in charge of that list to make sure that whoever is working with the patient gets it done. So whether that's the MA or the provider or the pharmacist or the fill in the blank for that patient. So everybody is encouraged to do it when the patient is with them and do it when they're with the patient, but it does fall back on nurses to go through the list and make sure that the care plans are getting done.
Sounds great. Well, thank you. We are at the top of the hour, but thank you, Ziva, and thank you, Amberly and Mary, for the presentation today. It was very, very informative. We've had a lot of questions, so sorry to those who we couldn't answer on the live webinar, but we will be following up with you via email to get those questions answered. If you have any additional questions, feel free to reach out to us at the PCPCT SAN. Liza or I, Jacinta Smith, will be happy to speak with you and connect you to the resources that you need. And again, this webinar is being recorded and the presentation slides will be available on our website, and you'll receive an email since you're all registered for that tomorrow or sometime today. So thank you again for attending, and please have a great rest of your day.
Thank you. Bye.